It's my pleasure to welcome Dr. Indira Natarajan to the Geko Sky Medical sponsored symposium, where he'll be talking on the use of the geko device, a neuromuscular electrostimulation device for the prevention of venous thromboembolism in patients with acute stroke. Dr. Indira is a consultant stroke physician and has held leadership positions within stroke care both regionally and nationally, and has always been a champion and ambassador for stroke victims, working to raise the profile of services in all aspects of care, from stroke prevention to end-of-life support for stroke patients in the community. He is widely respected for all of his innovative work. His work has also played a key role in winning several awards for innovation in stroke practice, including Health and Social Awards, and for Stroke Services and the Healthcare Pioneers Award, showcasing best practice in AF. Dr. Indira will present shortly, and please do use the chat or the Q&A button to submit your questions, which he'll happily take at the end of the session. So without further ado, thank you very much, and I will pass over to Dr. Indira.
Thank you, Joe. Thank you very much for that kind introduction. And just about my background, I'm a practicing stroke consultant in University Hospital of North Midlands in Stoke-on-Trent. So this work that we done was on the hyperacute and acute stroke unit. And just a brief background about patients with stroke. Stroke is the fourth major cause of death in this country and the biggest cause of adult disability. And any stroke units, after a patient has had a stroke, either it's an ischemic or hemorrhagic stroke, there are periods of time when they are immobile, risking them into post-stroke complications. And major complications that we face in our day-to-day clinical practice are aspiration pneumonia and VTE. So those are the big challenges in a stroke unit. So coming on to VTE, I'm just trying to move the slides just a second. Oh yeah, sorry. When first introduced to the geko device, we were aligned and still are to the UK NICE guidance, which clearly specifies that after a patient is admitted with a stroke in any stroke unit, we do a risk assessment, and once patient needs VTE prevention, the standard of care is obviously hydration, aspirin, and use of intermittent pneumatic compression. There are certain units, after a brief period of use of IPC, they move on to low molecular weight heparin, or delay the low molecular weight heparin after a period of safety immediately post-stroke. The Sky Medical Technology discussed with us the CLOT3 study finding, and CLOTS3 was the study that advised us to use IPC. CLOTS2 basically showed that TED stockings were no use in post-stroke patients, and overnight we got rid of the TED stockings across the country. And then we moved on to the CLOTS3, which showed that IPC was the choice as first line when patients with stroke immediately post admission to hyperacute stroke unit. The CLOTS3 study, however, showed that 30% of the population were non-compliant to IPC. And basically, it shows that if you don't have any sort of VTE protection post-stroke, the risk of VTE is 8.7% when you don't have any prophylaxis prescribed. That is either drug or IPC. So we wanted to make sure is in real life, in any stroke unit like our unit, where we see around 1,300 strokes, is that really a 30% of patients who are having problems with compliance with IPC? We didn't know. That was the data from the trial. And we wanted to open to explore our unmet needs. If it was 30%, and if we had standard of care, what other things then we can have up in our armory to protect these 30% of patients with a VTE prevention? And so this led to a sort of an observational practice that we adopted in line with the standard of care, and where we couldn't use the IPC, we wanted to see what is the role of geko. So basically, I'll just tell you about the device. This is the geko device. It's about the size of a wristwatch. It's battery powered. It's disposable. It's a neuromuscular electrostimulation device, which has got a constant current output. So what it does. So basically, the device is worn at the knee. The way the device is worn is the head of that device sits on the head of the fibula. Then once you on the device, it stimulates the common peroneal nerve, and the common peroneal nerve activating the calf and foot muscle pumps increases the blood flow in the deep veins in the calf. It's said to be around 60% of walking without a patient having to move, and uh, and that is the front of the device, where you can see that you got a plus sign and a minus sign. That is to adjust to make sure that the common peroneal nerve is stimulated, and we know that by flexion and dorsiflexion noticed on the patient's legs. So that is how we know that the device is the right for the patient. It's activated, and once we know that the patient's feet is moving slightly with the dorsiflexion and plantar flexion, we know that the device is in place and it's working well. That is the back of the device, where you have the gel which attaches to the skin of the patient. And it needs a bit of training to localize the head of fibula, put on the device, and then adjust the plus and negative signs so that the patient's uh, feet dorsiflex and ankle flex, and then we know that the device is in action. Regulatory approvals, it has got the regulatory approvals, is prevention of venous thrombosis, increased blood circulation, and prevention and treatment of edema. But clearly in our unit, we were focusing on prevention of venous thrombosis. So just a few words about VTE burden, causes, and current prophylaxis. And we all know what a massive importance in VTE in hospitalized patients. It kills one person every 37 seconds in the Western world. 25,000 people die each year in the UK from VTE, and hospital-acquired VTE, DVT can exist in any care pathway and affect any patients who are immobilized. So it's not very pertaining to stroke as well. So, I mean, all of you are aware that the way how venous thromboembolism forms is on this Venn diagram. When you have hypercoagulability, when you have stasis, and when you have vessel wall injury, you're prone to thrombosis. And post-stroke, when patient is immobilized, they have venous stasis. They are hypercoagulable because they are dehydrated. They're not eating, drinking, or they're not started on nutrition. And very occasionally, you'll have vessel wall injury as well. Sorry about the PowerPoint. Right. Okay. So the current sort of guidelines in stroke, as I said, was we got rid of the graduated anti-embolism stockings. Intermittent pneumatic compression device is the gold standard after aspirin and hydration. And clot study showed that the non-compliance should be greater than 30%. And anticoagulants are not to be used in immediately post-stroke because of the risk of hemorrhagic conversion of the acute stroke, and you can't use it in primary intracerebral bleeds. So we looked at the nice guidance, MTG 19, which supported the use of geko for people who have high risk of VTE, for whom pharmacological or mechanical methods of VTE prevention are impractical or contraindicated. So basically, it means that the gecko is approved for unmet needs. It is no way to displace the current standard of care like aspirin, hydration, and IPC. If you want to completely displace it from the pathway, we need an RCT, and an RCT is underway, but at present, standard of care is still aspirin, hydration, and IPC. So where are IPC contraindicated? So if you look at the conditions, arterial disease, neuropathy, fragile skin, allergy to current products, heart failure, and leg edema, when you have all these conditions, they are a strict contraindication for IPC. On these group of patients, we can't apply IPC. That means these are patients who are the unmet need. And there are other practical problems because it needs a power supply. IPC wire leads might cause trip hazard, and it's very difficult for the patient to get out and go for toilets during night times. And it feels as if the patient is tied down to the bed, and IPC restricts therapy people to come in and go. And some of the patients are unwilling to wear IPC compression sleeves because it's constant squeezing of the device prevents them from sleeping. It feels very uncomfortable. So apart from the contraindication, there are people who are non-compliant to IPC as well. Again, low molecular weight heparin, some units still use it after 48 to 72 hours, but there are issues with active bleeding. You can't give it in acute stroke when you have problems with your full blood count, a very high blood pressure, or patients with bleeding disorders. So again, drug prophylaxis can't just displace IPC. So there are restrictions. So the NICE guidelines, health economics said that 6 days of gecko use will save 197,000 pounds per patient. And gecko is cost neutral across 15 days, and gecko is cost neutral across 3 days if combined with chemical prophylaxis, that is drug. So what we wanted to do was we wanted to see how the gecko would fit into our pathway in our stroke unit in the journey of the patients after hyperacute stroke. So the patients who would go onto this gecko device when there is a contraindication or when they could tolerate are all groups of strokes, both ischemic and hemorrhagic strokes. And we also used in a group of patients who had subarachnoid bleed, although they don't come under the stroke umbrella. Consequences, potential consequences, temporary or permanent loss of limb movement, prolonged immobility, loss of calf muscle, pump activation and function, and increased risk of stasis. These are post-stroke. And gecko naturally helps in muscle pump activation and antistasis, blood flow enhancement in the deep veins of the calf, as I alluded in the previous part of my talk. And this was the CLOTS 3 trial, which clearly showed that the VT incidence is around 8.7% if you don't use any IPC at all. And with IPC, there was another 2 to 3% reduction of VTE, and non-adherence to IPC was around 31%. This was from the actual trial data. And there is a lot of evidence to say that drug prophylaxis is quite dangerous in the hyperacute phase or in the acute phase, because the benefit of VT prevention outweighs the hemorrhagic complications. Hemorrhagic complications are very dangerous post-stroke, and symptomatic intracerebral hemorrhage outweighs the benefit from VT prevention with routine anticoagulation. And it's very difficult from both the papers to judge which group of patients will be safer to provide the low molecular weight heparin. So there is no clear data. Although some units use it after 48 to 72 hours, there isn't any sort of data to predict bleeds during this time. So what was our findings? So what we did was we used it in the consecutive patients coming in through the stroke unit, both ischemic hemorrhagic strokes. And we initially wanted to look at the data after we've seen the use in 1,000 patients, but we've now reached, although it says 3,383, we've now reached around 2,500 patients where we are still analyzing the data. And the real world data showed that 29.5% patients that required mechanical intervention were contraindicated. So we wanted to see, was that true? And we also wanted to measure what was the VT incidence 90 days post-stroke. And what our study showed that the real world data was very, very similar to our experience. Around 30% of the patients were not able to tolerate the IPC. And we had 11 VTE events in patients prescribed IPC alone compared to no events in the when we use the gecko device. And the gecko has to be worn on both legs for 24 hours a day. The average time were between 5 to 9 days, or until the patient was mobile or no longer needed the gecko device. So that was the audit results in a sort of a pie diagram. 463 patients out of the 1,000 were using the standard of care, that is the IPC. 122 of them went on to the gecko on its own. 81 of them were initially started with the IPC, couldn't tolerate, and had to go on to the gecko. 125 went on to drug prophylaxis, 22 refused prophylaxis, and other 187 patients who have minor non-disabling strokes where no VT intervention was needed. So in total, there were 203 of these patients who had the gecko during their journey, during the hyperacute and the acute phase of the hospitalization. So this is to just show that this matched with our real world data compared to the CLOTS 3, that 11.7% of the patients were intolerant to IPC because of because they were not able to wear it, although that was the first line of treatment, and immediate contraindication around 17%. So as soon as a patient arrives, when you looked at the direct contraindication, 17%, we couldn't clearly apply IPC. But another group of patients went on to the IPC, where 11% started on IPC but couldn't tolerate. So in total, the patients who couldn't tolerate or contraindication were around 30%. And in terms of tolerability between the gecko and IPC, gecko was better tolerated compared to the IPC when we did patient surveys. And this is just a bar diagram to show that of the IPC alone, who had 463 patients, we had 11 VTEs, and compared to the 122 patients who had the gecko, there wasn't any VTE. So basically, our our study concluded that gecko was as safe and as effective as IPC, but in the absence of RCT, we could only come to a meaningful conclusion that it is one of the modalities that we can use as an armory in the journey of the patients, but we can't displace what has been the standard of care until we have a direct RCT comparing IPC versus the gecko device. So this brought about a change in nursing clinical practice at Royal Stoke unit. What it brought on was it just changed the outlook in how we manage our patients with regards to VT prevention. We had to adopt a new working style because unlike drugs, the drugs can be given, and we certainly know that the patient has had the drug and they have the 24-hour protection. But with IPC and the gecko, these are devices, and these are only effective when the patient wears it 24 hours a day. So we had to change our practice in such a way that we had healthcare on 3 shifts going around the ward to make sure that the VT devices are in place. Because in most of the times when we were using the IPC and we were doing ward rounds, when we come on the ward round in the morning, we'll notice that the devices are hanging out or slipped out. So we do not know when the IPC has come out, and these patients are at vulnerable for venous stasis and VT formation. So we wanted to make sure whether with the IPC or the gecko, we had 3 visits by a healthcare, just doing a round on all patients who got this devices to make sure that they're worn. So that's very, very important. Because unlike drugs, these have to be worn on the patient to make sure that it prevents VTE formation. And our data influence a lot of other hospitals across the UK to adopt the pathway which we had adopted in our unit. So there were lots of things that we had to go through to get this as a normal pathway of VT prevention. We had to get patient groups. We need to make sure that we adhere to the standard of care with aspirin, hydration, nutrition, and then we had to start off with IPC. We were very, very clear that we'll not use a low molecular weight heparin during the hyperacute and acute pathway. And then we had to make sure that the device was safe and met all the requirements of safetiness. So we had to go through a stringent governance policy within the hospital. So we had to work through a lot of groups of people. We had to work with the divisional governance, the VT steering committee in the hospital, the pharmacy procurement, and most importantly, patients. We also had feedback from all the patients who wore the gecko and also the families. We had some feedback on the nurses in applying the devices and what sort of skill sets they needed. We had to train a group of nurses on a rotational basis, that all of them know how to apply the device and make sure that they know how to take it out and how safely to dispose it. And these devices has to be changed every 24 hours. And so we also had a lot of support for us to get this on a database, and had time allocated to look at the VT rates on discharge, 30 days, 60 days, and 90 days. And participant patients received regular follow-up once they had left the unit as well. So this is just a sort of a diagram, just to show the pathway that we went. We clearly knew that there was a challenge for patients with stroke, that all of them did not meet the standard of care with VT, because there was a group of patients who couldn't tolerate IPC. So 8.57% risk of VT with no prophylaxis. We were worried about the bleeding risk with low molecular weight heparin, not recommended, high risk of intracranial hemorrhage or a hemorrhagic conversion of acute strokes. We knew that compliance was a major issue with IPC. So then we looked at what was the unmet need. The unmet need was around 30%. So we wanted to see what are the other treatments that are available apart from what is standard used. And then we came to know about the scientifically proven, which was, sorry, NICE approved. And then we brought that into our practice, and then we audited the patients, over 1,000 patients, and we clearly came to the conclusion that gecko was as effective as IPC on the patients who could not tolerate the standard of care. And now there are a lot of hospitals across the UK who are now adopting our pathway. So what we did was we did our work published, and also as a poster we have displayed it in many international conferences, and it is available. And our data, what we were worried was this just a one-off data from a one single hospital site, and whether this could be extrapolated into other units. And then we looked at the Luton and Dunstable team, which exactly did what we did in our unit, and they extrapolated our pathway into their hospital, and they are a big unit seeing around 1,200 strokes a year, very similar to our size up. And their data was more or less similar in terms of experience. Their unmet needs were around 30%, and their use of gecko really revolutionized the group of patients who couldn't tolerate standard of care, that is including IPC, aspirin, hydration. And now these hospitals have device, and now it is part of our drug chart. So when we look at our drug chart, we have a VTE risk management, we have to sign that, and then we have use of low molecular weight heparin, and we have the use of gecko. So in majority of our patients, we have IPC as well. So they'll sign up for IPC. If the IPC is contraindicated, we'll sign up for gecko. Every day when the gecko device is changed, the patient will, the nurses will sign on as if as if it was given. But I had to emphasize that unlike drug, we need to make sure that there are ward rounds dedicated to make sure that the devices are in place. There should be a morning round, there should be a midday round, and there should be an evening round. Just a quick round to make sure that these devices are in place on the patients. Only then you'll have the benefit of VT prevention. If not, if the device is out or if it's on the ground, that means the patient is at risk and they are at risk of VT formation. So that is what was our experience. And I hope I was able to tell you where we started and how we ended up using the gecko device. And I have to emphasize again, this is only used for patients where standard of care is not possible. Again, aspirin, hydration, IPC, and we found that 30% there was an unmet need, and now that unmet need is more or less met. There are still a group of patients who can't even tolerate gecko as well, but that's where we stand. I hope I tried to give you an idea of where this project started and where we are at present, and I'm happy to take any questions.
Thank you so much, Dr. Indira. That was really informative and really interesting to see that this important group of unmet needs has been identified and helped. And just to reiterate, so in a roughly 30% of this, of the unmet need, this device is now approved by NICE and recommended for that particular group. Is that my understanding is correct?
Yeah, I mean, NICE would not recommend it as guide as a guidelines, but they would just say that when your standard of care is not possible, then the role of gecko is for that group of patients. So that is where NICE recommends it, and that is where we are using it as well. That's right.
And it's also very good to be able to see that both in your trust and now in others, the evidence that you showed is being mirrored elsewhere, reassuring to both the users and the patients.
Yeah, exactly. So when other units are coming, they're just saying, oh yeah, it's interesting because we have got the same problems with standard of care where IPC is not, patients are not able to tolerate. There's a big group of patients where IPC is contraindicated. So they have now added on the gecko to the pathway. So once standard of care fails, there's a big group of patients who are not left without any VT prevention at all. So our argument was 8.7% VT incidence when you're not prescribing any prophylaxis. So we wanted to make sure that every patient has some sort of a VT prophylaxis.
I think it's important that, this is already a very vulnerable group of patients, isn't it, who have suffered.
Absolutely, yes, you're right.
Yeah. Can I just check? So if patients, first of all, were suitable for a therapeutic prophylaxis, they wouldn't receive the gecko device. It's for those who are contraindicated along the pathway.
That's right. Chemical prophylaxis, which commonly used are low molecular weight heparin, right? And hyperacute acute stroke, both ischemic and hemorrhagic, low molecular weight is contraindicated. There are some units who go past this by using low molecular weight heparin 72 hours or a week down the line. But again, they use IPC as the first line. But here we are saying that the risk of drugs, we do not know which are the group of patients who will end up with the complications of low molecular weight heparin. So we did not go through the drug route, and we wanted to see if there's anything alternate to the drug route on patients who can't tolerate IPC, and that's where gecko fits in.
You mentioned about you needed to train up staff. One of the jobs or roles was to go around and make sure 3 times a day that the device was on properly so that it was actually working to its full effect.
Absolutely. That's very important. When we went on and started the use of IPC as standard of care, one thing that I know, or clinicians across the country would vouch for this, you do go on for a morning ward round, and sometimes you notice that these IPC sleeves are on the floor. You do not know when they have, when you sleep and when something is just really compressing on your legs, you, even without being aware, try to move your legs and dislodge these sleeves. And our units were not prepared. We didn't have the workforce to go and look around whether the sleeves were detached. So we found them on the morning. So this must have come out around 11 o'clock at night, and you're seeing them at around 8 o'clock in the morning in the ward round. Although this was introduced, what we didn't take on board was this, not unlike drugs. Once drug is into the system, we know it acts for 24 hours. But these devices are devices which has to be worn 24/7. So when we build something of a device into the pathway, it is very, very important and paramount. We train our nurses not only to apply the devices appropriately, we need to have sort of for every shift when they come in, they just do just like a drug round, they just do a VT round. It only takes a couple of seconds to just lift the patient's sheet and see whether the device is in place. But it is very, very important, because if it is not there, they are the risk of forming a VTE.
Yeah, and I guess it also gives that opportunity to just check with the patient, they understand why it's there, and they become more adherent to it. Can I ask, in that training process, was everybody trained on how to fit the device, or is it left for pharmacists or doctors? Who actually fits the device at the beginning?
No. It's very important that the healthcare and the nurses are trained up. They are the group of people who, after the wash of the patient first thing in the morning, will do the VT prophylaxis. Either they'll put the sleeves on or they apply the devices. So we had a huge cohort of nurses trained. And every month, initially when we went into the project, every week we had 10 or 15 people sign up for the training and the competencies checked. Once around your majority of your nurses started to understand, then they transfer the knowledge to other people who were watching. So in that way, we got the whole unit trained. It's the training is not that it's quite easy to apply the device. And once you start applying, and once you're feeling confident, and it's very, very easy. And what happens in the mindset of the nurses who apply the devices, they just ask, why can't we use the gecko as a front line? So we need to emphasize to them, still the evidence is the IPC is the standard of care, and it's only for a group of patients where IPC is not tolerable or contraindicated. We can go onto the gecko device, and it's liked by patients. And you should see therapists when they come in to do a therapy. If somebody's on an IPC, it deters. It looks like you're connected to the bed. You want to get them out, get them walking. It's also the mindset for the patient that they feel that they are a bit more independent without any attached to the bed.
So the patient can really walk around, go off to the toilet.
Absolutely. They don't need to wait for somebody to come and remove these, and then, so they can just have the independence of the device is already there in the leg. They can just carry on with what they're doing.
And is it waterproof if they were to shower or anything
It is.
spill?
It is waterproof, but generally before the shower, that's the reason why we change it when they're having the shower in the morning. Once they wash, because this can't. Although the battery life is 36 hours on these devices, the recommendation is we dispose after 24 hours. So it has to be changed every 24 hours. So that is a time when they go for a shower or wash. You remove it, have a shower, and then you apply it back.
So looking at that pathway, when you're prescribing it at the start, once you've done your training, does anybody within your team prescribe it, or again, does that come back to perhaps the doctor or the pharmacist, or are there nurses who are trained who can do this?
Yeah, the only the prescribers can prescribe. So it's just like a drug, although it's a device. So what we do is we do a risk assessment, and once we risk assess the standard of care, we always tend to start with IPC. But the nurses will come and say that we can't wear IPC because the patient has got edema, or they got a very vulnerable skin, the skin care is poor, or there are ulcers. So then we will just say, okay, we strike off, and then we put the gecko as we'll prescribe the gecko. Or sometimes the nurses will say on the ward round, or the patients will say, I don't like the sleep, it's not allowing me to sleep. And the night nurse would have reported to the day nurse that they couldn't tolerate the IPC. On the next day ward round, we will change the IPC to gecko. But it is a prescribed, it has to be prescribed. So nobody can apply the device without signing on the prescription chart.
Some questions are coming in, and certainly from a trust that are introducing and applying the gecko. And one of their challenges is around prescribing, but the other one is also not taking off in time. So how have you overcome that to make sure, because obviously there's a time issue on this, but to make sure that those on the ward make sure the device is changed in a timely interval?
Yeah, as I said, it's the battery life in this device is 36 hours. So you don't need to exactly remove the device. If you apply it at 9 o'clock this morning, it doesn't need to be removed exactly at 9 o'clock the next day. Every patient will be washed the next day. It could be at 8 o'clock, it could be 9, or sometimes 10. So it's at the time of washing, they change. Or there'll be a ward round, there'll be a drug round in the morning. Some patients who are who are hoisted, or who doesn't have a wash, or for some reason, it'll be like in the drug round, they will change the device. But as I said, the most important thing is to make sure that the round is looking at the patient wearing the device. That's very, very important in mechanical prophylaxis.
Yeah, and obviously that the drug round would also check
Yeah.
and monitor that. So that's brilliant. Thank you. Practical things. Does the gecko need to be removed at the time of an MRI or any other scan or procedure?
Oh yeah. One important thing is the gecko has to be removed when you're doing an ECG, because it's an electrical device. You will feel as if the complexes are paste complexes. So when you're doing an ECG, if you look at an ECG on a patient with gecko, you'll think, oh, has this patient got a pacemaker? So you have to take the gecko out when you're doing a 12 lead ECG, but it's not contraindicated in MRI now.
And can the same gecko be, so if you take it off for an ECG, maybe 20 minutes, you can put the same one back on, you don't need to get...
Oh yeah, so what they need to know is when they're doing an ECG, the moment you do the ECG, you'll notice that the tracing is not normal. Then it should immediately twig, why is the tracing not normal? All right, now it's all bedded into our system. We'll know, we'll look at an ECG and say, oh, the patient is on gecko, can you just remove the gecko device and do the ECG? So it's quite easy, it'll bed it into the system very quickly.
Has the feedback from patients been really positive about this?
Yes. What we did was, before we introduced the gecko, the first thing we wanted to do was, what is it different from IPC? IPC squeezes your calf muscles, and this stimulates your peroneal nerve, and there is a bit of a jerky movement in the leg. Is that tolerable when you're sleeping or when you're sitting? So what we did was, we had around 12 consultants, and we had around junior doctors. So for 24 hours, we all wore it to see whether we can tolerate it ourselves before we subject it to patients. So the first 5 or 10 minutes, there'll be a slight bit of discomfort. You will be aware that it is on. But then once you go on past the 10 minutes, I was skeptical when I saw the device, and when I noticed that it has to create a jerky movement. But then you can just carry on doing your normal work. So it was tolerated well by patients, and we wanted to make sure that all the patients were able to give back feedback. We did ask them, compared to giving the explanation, that this is something to prevent stasis and complications, and would this something be you would be happy? They said anything to prevent a complication, yes. as far as it's not an injection, they were more than happy for the device. It good feedback.
Definitely, thank you. Can a patient be discharged from hospital using this and continue using
No.
it?
No. See, the time we stop the device is once the patient is ambulant. So that is why when patients are mobile after a stroke, neither IPC nor the device is used. That means they are mobile, so they are not at risk of stasis. The time when we decide to take the device is exactly like any other VT prophylaxis in hospital. On the day of discharge, we take the device out if they're going out. But if they are going into long-term rehab, where their length of stay in hospital is more than 30 days, we made a conscious decision that we'll not use the device after 30 days. We will probably move on to alternative drug like low molecular weight heparin, because we felt that the first 30 days is the risk for low molecular weight heparin induced complications. So 30 days was the time limit. After that, none of them had a gecko device.
And can the device, you showed in one of your slides the imaging on it and setting of it. So how do you decide, and can you set it at an individual level for the
That's right. So it all depends on how the current is, what level of current is needed to stimulate the common peroneal nerve. Some people will be very, very thin individuals where the nerve is very below the fibular bone. The moment we put the device and press the plus sign, within one sort of increase in the amplitude, the device will start generating the dorsiflexion and flexion movements, and we know that that's the right setting for the patient. But sometimes we'll have to increase the frequency, or we'll slightly move the device so that we just adjust it. If you apply it for 10 patients, you'll find only one or two patients you will not get it the first time. You'll have to just slightly do some adjustments. Majority of the patients, as soon as you put it on the femoral head and you start it on, you'll get the right sort of strength, which will stimulate the flexion and dorsiflexion.
And I guess that will be reset if needed each time the fresh one is
Yeah,
set.
absolutely. Yes, every time. Yes, you're right.
And is there training available, not just from yourself, but from the company, the supplier?
Oh, yeah. Training is always, now the training is available online, but I think nothing like face-to-face training, because you just actually play around with the device on yourself and then you take them to the patient. Initially, when anything like these comes up, a new kid on the block, or you have any sort of new devices, you're worried whether we can get this into real-time practice, because you got shifts, you sometimes have agency nurses coming in and ad hoc. So even the agency nurses who come in as locum, within a day or two they get trained. If they are to stay for a week, we can get them trained. And so training is not a massive issue. It's just a rolling program that we always set.
Yeah, and I guess it's part of the whole care program for these
Absolutely, absolutely, you're right. Yeah.
And somebody has said, in the training, don't forget to turn it off when you're removing it as well. But that will come in as part of the training.
Yes, because turning it off, and you can't dispose the device. There are separate because it's a device which has got a battery in. There is a mechanism in which they are disposed, so they need to learn about disposing the device safely as well. So that is the part of the training. So it's just not like you can't like how we dispose the sharps. There is a mechanism in which we dispose these devices safely as well.
So it's part of the whole procurement and processing of the pathway.
Yeah,
I think we've exhausted all the questions, but just to go over as well some of the facts that you showed. So there was over 8% of these very high-risk patients who were suffering VTE, having used this in your cohort of patients, which is quite a number. You've noticed that the incident of VTE in this high-risk group and with unmet needs has considerably declined. And have you had?
That's right.
Yeah.
It's considerably declined, but as I said, if we want to really see the benefit of changing the practice completely, we definitely need an RCT of a head-to-head study. And we are working towards an RCT. Probably it will be launched next year. But until then, as you said, if they have no prophylaxis, the VT incidence is 8.7%, but if they have and good units and good places, the VT incidence significantly is reduced if you use them appropriately.
Thank you. If anybody wants to find out any more, obviously you yourself with your unit, but also the 5 others that you know locally you've worked with and have rolled this out, would be very happy to be approached and discuss it and see it in practice. I also am aware that within the platform, the Let's Talk Clots platform in the exhibition hall, the device company geko have a stand where you can ask questions and learn more information about it. So
Absolutely.
there's a lot of support out there as well as information, and
Yep.
happy to be contacted as well if people want to ask you questions directly.
Absolutely. I mean, people get contact us. It's not that they are not willing to try it. It's just the process of adopting anything new in the NHS. It's for the right reasons, because you have to go through a governance framework. We need to make sure that the device is safe, the device is does not cause any harm to patient, and if it's been used elsewhere in a bigger organization and in a lot of hospitals, so new units have that data to support that they can safely use them in their unit, and it'll be easy for them to go through the governance because it's been tried and tested elsewhere. So we can help them in getting them into their practice as well.
That's brilliant. Yeah, definitely. Thank you very much, Dr. Indira. A really informative presentation, and this will be available for others to either catch up or watch again by the end of the day. So thank you very much.
Thank you very much for your time, and thanks for your attention and listening to me. I hope I've influenced. I mean, this is something that we see in our practice, and we don't want a group of patients to be left alone for lack of evidence. So that's the reason why we ventured into this, and we did find that there is a place for these devices in VTE prevention.
Thank you. Bye-bye.
Thank you. Bye-bye.